Now, I would like to turn our meeting over to the first of our speakers today, Christine Bechtel, who is co-founder of X4 Health. She's a well-known consumer advocate with expertise in areas ranging from social impact design and movement building to patient and family engagement, health IT, quality measurement, and improvement. And she will be talking, addressing today a very important topic for us. Christine?
Thank you, Bob. Thank you guys for having me today. I am going to share my screen and throw some slides up here. Let me know if you have any trouble seeing them. But I'm very grateful to be here today, not only as a patient advocate, but also as just a big fan of primary care. I love primary care. I'm a big fangirl of Bob Phillips and Becca Etz and Asaf. So thank you guys for having me. I was asked to do this talk around a national program we built and run called The Third Conversation, but that was before COVID happened. And I feel like this is a really profound moment in time for us. So I rebuilt this talk. I'm going to go pretty quickly through what we have learned about primary care from The Third Conversation, but I'd like to use it as an opportunity to focus a little bit more on some big picture thinking around what primary care might look like in the future. And that experience is informed for me, not just by The Third Conversation, but by many years of working in and around some of you in primary care, working on things like the Shared Principles for Primary Care, which I co-chaired with Ted Epperly and Julie Shills, and working on with FMA Health and with PCPCC and with Becca at the Starfield 3 series. So lots of broad perspectives have informed me, and I'm going to move quickly. So I'm going to hope that you guys can capture any questions you have around things that I skip over. I hope that you'll invite me back to cover some of the more moving and inspirational stories that we've seen and heard from The Third Conversation. So we founded this idea of Third Conversation primarily because we felt like the triple aim was missing something. I have spent most of my career thinking about and working on and lobbying for national public policies that will make healthcare better for humans. And in the 25 years or so I've been doing that, we've really predominantly focused on the what and the how, or what we might think of as the structural and the technical. So our fundamental question in creating The Third Conversation, which is a foundation-funded initiative, is really, could the cultural and relational stuff, the who and the why, could that really change healthcare? Maybe change some of the types of solutions we develop and maybe even accelerate those solutions. Couple of disclaimers about Third Conversation. First of all, it's not a panacea. So it's not meant as a replacement for the triple aim or for quality improvement or for all of those great things. It's also not meant for everybody. It is not going to resonate with some of you today, and that's okay. And for those of you who feel moved by this concept, let's talk. It's also not a patient forum. So it's not a patient and family advisory council. It's not a purely patient input forum. It is a real conversation where frontline clinicians are coming together with patients and families to get real and talk about what the healthcare system is like for them, whether they're working in it or receiving care. So I'm going to do the first about 90 seconds of a quick video here. And somebody flag me if you can't hear it once it does start.
I'd say 3C is the story of a bunch of people who were concerned that the existing healthcare system, especially our primary care delivery system, isn't working for patients and it's not working for practitioners. And we thought, what would happen if those people actually sat down and had a conversation together?
We realized that the human toll that the system is taking on patients is also having a disproportionate impact on clinicians. And we thought to ourselves, has anybody ever brought these two conversations together? That's why we call it The Third Conversation. We were hearing the conversation at the national level about clinician well-being and burnout. When we began to look deeper, what we learned was really stunning. We started to see that, half of clinicians are screening positive for depression. We learned that almost 10% have suicidal thoughts. These are the individuals who we are asking to heal, and they are having just as hard of a time.
When we were envisioning what this might look like and feel like, I think we expected people to talk about what was wrong. we expected people to talk about what they wanted from the system. I think we were really surprised, though, how therapeutic those conversations would become for both participants. It was really surprising for us.
I think their conversation is unique because it's grounded in that purpose and in that empathy, that bi-directional empathy. So I think, unlike other initiatives, their conversation is a platform for building community in service of a better system.
So privileged to get to work with some amazing humans. So the backbone of the third conversation are these Spark events. They're 3-hour professionally facilitated events. They're half patients, half frontline clinicians. They are interprofessional. They are primarily primary care. And we ask these patients and these clinicians to think about their own experiences in the system collectively. And then we ask them to unpack them. And we do this based on the ideas and the science around empathy. So if you can unpack those experiences and understand the emotions that drive our actions and the fundamental needs, the human needs that are being met or not being met in the system, then we can begin to operate from a different level within ourselves. So we talk about not brainstorming, but dreamstorming from those places. And we ask them to identify those best of MVP moments and identify the enablers that made those possible. And then from that platform, really think collectively about what a desired future could look like. So a couple themes for you that have emerged in these events. Number one, this is actually really profound. Patients and clinicians want the same things out of healthcare, but we are set up as adversaries in the system in these really subtle and sneaky ways. Think about even just the example of time together. Patients want more time with their clinicians, but clinicians can't give it to them, even though they want it too. Many more examples that we can share with you. The relationship as it is today, confined to these 12-minute office visits dominated by documentation requirements, it's broken. For primary care, you guys, this is a huge red flag. It's not your fault, but it is happening within this larger system and we have to address it. We've learned that just creating simple human connection, not necessarily even the quote doctor-patient relationship, but profound human connection is really impactful and it changes the way people show up in the world. We were at a Ryan White clinic last year, and I'll just give you a brief story about that. We had paired in this conversation, there's a 20-minute segment where an individual patient gets paired with a clinician. And in this case, it was a white doctor, probably mid-50s, paired with a young transgender African-American woman. And when they started out, every part of their body was just closed off from the other. Like arms are crossed, their legs are crossed, their ankles are crossed, you name it. They're leaning way back in their chairs. And within 20 minutes of conversation and connection with each other, the clinician, the physician at the end of the night, he stood up and said, you know, this is why I went to medical school. And I'm going to start tomorrow. I'm going to re-engineer my office visit completely to facilitate this kind of human connection 6, 8, 10 times a day, because that is what sustains me. And even though there is a personal cost, I'm going to have to do a lot of documentation later. I'm willing to create these changes in my workflow to facilitate this connection for me and for my patients. So we've learned that there's a lot we can do individually. There's even more we can do collectively. So I want to share with you some insights about what I would call pre-COVID primary care. The system creates a lot of emotion in people. We tend to hear a lot about the negative side, but we also hear about the positive side. When we ask them to talk about and unpack enablers, I've gone through all of the sticky notes. You can see we're a big fan of using sticky notes in these events. It boils down to 3 things that really create a positive experience and better primary care: time together, human connection, and coordination and communication. So we think about the desired future. We ask them to just Dreamstorm. Just imagine we've worked together to achieve something beyond our wildest dreams. And I want to tell you that what they've come up with, this is what I hope you guys will think about in your deliberations and in your recommendations. It's big picture stuff. Number one, they both want to change the economics of healthcare. They both recognize, patients and clinicians, that healthcare has really become a business. And we did focus groups last year, and I heard language coming from, average patients that I'd never heard before in 20 years of patient advocacy. They were using words in these groups like value-based care and ACOs and Epic, the health IT vendor. And my sense is that clinicians are so angry about working in a system that isn't working for them that it's spilling out onto patients, and we're overexposing them to these real challenges that we have. They want to change the economics. 2, they want to reimagine access to care. This has both a cultural dimension, but also kind of a technical or structural dimension. So on the cultural side, thinking differently about the team itself, and we can talk more about this in Q&A, obviously changing the physical access. But this also means, we hear a lot, like people are not understanding, why have we bifurcated mental well-being from physical well-being? How does that even work? And how do we bring community resources and services more into the picture? They define success in a different way. They want it defined in terms of health, not just medical care. This is where I think as a U.S. system, we've really fallen down. And they also talk about working together in a different way. I'm going to come back to that in a minute. But the bottom line is our sense is that relationships are both an end and a means in our system today. They're an end in the fact that they're fulfilling in and of themselves. They help address burnout and professional well-being as well as patient experience, but they're also a means to getting to better care as well. So really important to think about how to centralize that in your deliberations. So here I want to say, first and foremost, my take. Be bold. This is a completely new context that COVID-19 is opening up for us, and this is not the time for business as usual. Second of all, I'm wondering whether primary care practitioners actually should become relationship specialists. When I say that, I don't know of anybody else who can do it this way except primary care. Like, this is an area that only you, primary care practitioners, can compete on. Others can compete in a lot of other areas, but I don't know anybody else who can compete on relationships. I think it's important to recognize the new reality and the current way that patients experience primary care. We have seen major changes pre-COVID, just in the last 5 years, let alone since 1996, when the committee originally published, the early IOM report. Today, we have minute clinics, we have plush care, we have concierge service, we have texting apps. All of those, by the way, are cheaper and more accessible than my patient-centered medical home. And to put a finer point on that, so my boyfriend, Mike, God bless his little heart, he has a patient-centered medical home as a primary care doctor. When he goes there, he experiences the usual trials and tribulations, wait times and blah, blah, blah. But it costs him $225 to go to his primary care doctor because he has a high deductible plan like many Americans do. Mostly they refer him out. They don't have labs on site. They don't have x-rays, blah, blah, blah. Or for $200, $25 less, he can go down the street to his minute clinic here. He has no wait time. They give him everything they need. They have a lot of co-located services. Their service is impeccable. And then he leaves with a digital copy of his health information, and it's less expensive. But the thing that is missing from that is relationship. So the very thing, primary care, my sense, has really been disrupted by the advent of these trends, but you can disrupt right back if you focus on relationship. Next question, though, I wonder whether or not all patients really need the kind of primary care that requires relationship. And I would love it if you guys would consider whether or not you really should specialize in treating the entire American population. That is a completely different thing than you're used to considering. I get that. But here's the thing. I think primary care, I can imagine a future where you offer all primary care services just like you do today, but you organize and you design around the people who need relationship most. People where having a relationship with a primary care practitioner could lift them into health and well-being in a way that no other minute clinic or whatever can. So there might be 4 different populations that you could imagine that this could really help if you really specialized in relationship. One would be vulnerable populations who are struggling with known drivers of health, what people call social determinants, but really we know is just housing, food insecurity, and jobs, known drivers of health. being able to orient and organize around that, if you can make the healthcare system work for these vulnerable populations, it will work for anybody. Chronic and complex needs, acute needs at high risk of becoming chronic or complex, and then what I would describe as tricky patients. So tricky patients, this is Mike, by the way, are those who will benefit from the kind of relationship-based coaching and motivational interviewing, patient activation, getting ready to change, feeling inspired to change, knowing how to change, those things that are greatly enabled by relationship. But handing off some of the people, like me, where I don't probably need a whole lot of primary care in that is relationship centered. I just need like some maintenance meds. I know that's completely different than how you guys are used to thinking about it. But remember that from a patient's perspective, we don't think just about the primary care system. So I could imagine a way that all of the other healthcare providers in our system actually orient as a sentinel system, like a network, so that when they, say my local pharmacist or my minute clinic, when they see that I am at risk as a patient of sliding into one of these categories, or whatever the categories are, that's when they intervene and they say, you know what, you need to get back to primary care. Your primary care clinician has an important valued skill set that can really help you. So if everybody orients around primary care, that's different than us trying to be all things. So I just want to push your thinking on that, and also encourage you guys to keep a really broad lens as you're going through these deliberations and understanding from a patient's perspective, health insurance design, the cost of care, public health, those larger systemic issues impact primary care, and you can't not engage. So really being intentional advocates on those issues feels important. Lastly, I want to say it's time for you to get in the foxhole with patients. So let's talk about COVID-19 for a minute here. When I talk about relationships, let me just say, I think also it's not just about relationship in the office, right? It's also about advocacy. And when I think about COVID-19, there is an opportunity here. Right now, somebody said the other day that they felt like this is our Holocaust, and what we have to do is get people to safety. That is absolutely right. And it can't end there, right? So when we think about, during Katrina, we moved people out of the 9th Ward in New Orleans to get them to safety, but we moved them to like other communities. And yes, those communities were dry, but we did not address the root cause of Katrina, which was climate change. That's the moment in time opportunity that I feel like you guys have right now. We have our own disaster in healthcare. Our failure to value primary care and public health is making us wildly vulnerable and blowing our system wide open. And if we don't address the root causes, this isn't going to work. We won't make it. What we know is that healthcare providers are hurting right now, not just because of COVID. They were already experiencing epidemic levels of burnout. We know that patients are hurting. And we know that these two constituencies don't actually have a solid relationship anymore. They haven't for a long time. That's what we have to address. These are the two sides that know the most about what healthcare should look like. And they have the most to gain and the most to lose if our system fails, and it will buckle under the weight. So I just want to be really clear to you guys, specifically to this Zoom room full of academics and clinicians. You don't have a single patient on your committee. That is an epic failure. That is antithetical to the profession. You guys have cornered the market on person-centered healthcare, and you don't have a patient when you need to have 5 or 7 patients who can really inform your deliberations. But this committee aside, I want to say that clinicians writ large, you can't do this alone. You can't do it alone, or it would have been done by now. You don't have enough power. You don't know. It's not about what we know. It is not about the what or the how of healthcare. We have to begin to prioritize the who and the why. You don't have enough power to do this alone, and neither do patients, by the way. No one knows that more than the frontline clinician in primary care. That's supposed to be our defining trait. And I would argue to you that the power is actually the relationship itself. If this were true, if this were true already, we wouldn't be fighting about people working at the top of their licenses. We would be working at the top of our humanity. We wouldn't be fighting over how hard it is to address known drivers of health, like food insecurity or housing or jobs. Like, of course, we would be caring for people's health and not just their medical needs. We would, of course, change the economics of a very broken marketplace. We would get to the root causes. But it is time to get in that foxhole together and to fight our way out of this. We have to stop screwing around. We have to recognize that the power is really in the relationship, and primary care is in a unique position to act and to re-engineer humanity back into our system as the defining trait. So I want to leave you with this, and this is going to make me very emotional, but this is a card that we put together as patients just to show our healthcare providers that we are here, we are staying home for you, we are here for you, and we are very grateful for all that you do. So I hope that we will do this together.
Christine, thank you so much. We have time now for the committee to ask questions. I'm going to kick it off. I'm going to ask actually about something that you used during your presentation, but you didn't talk about because I think you could help us. Thanks to Chris Kohler, Don Berwick admonished us to make sure that we used metaphors to help explain the problems and the potential solutions that we were framing, that it was really critical for our recommendations to be heard. What metaphors, and I think you talked about power of relationship, but what metaphors do you think we should be leaning on very hard in our report?
You know, Bob, I got to tell you, I am the worst at metaphors. So tough question for me to answer because I don't think that way. But what I would say is the idea of the opportunity that we have post-COVID to regroup together, to address those root causes, to think differently, not tinkering around the edges, but really valuing and prioritizing the who and why of healthcare. Like, that's the takeaway here, and you got to do it with patients. Like, if you take anything away, that's what it is. And this idea that you can actually organize primary care differently than we've been thinking of and doing for decades, that's huge. And that's what I'm asking you to consider.
Thank you. Are there other questions from the committee? I don't know that anybody raised their hand, but...
Chris Kohler had a question.
Oh.
Thanks, Bob.
Chris,
and hi, Chris.
Yeah.
Thanks, Bob, and hi, Christine. It's Chris Kohler.
Hi, Chris.
Hey, and thanks for a speed race provocation. Mission accomplished. You in this emphasis on you have this emphasis on relationships, but you also talk about kind of this fundamental failure to value primary care in public health. This is kind of a leading question, but I'm really serious. Do you see another way to express value besides money?
Yeah.
Is money the fundamental, the precursor? It's not the only, but is it the precursor, or is the starting place a process like what you're talking about, or a training mechanism? Kind of what's the order of battle to have a system they have a primary care system that is more relationship oriented in a society that values primary care and public health more? Thanks.
Yeah, thanks, Chris. And big fan of all of your work around investment in primary care. I would say that the starting point is health creation. And that does take us to a system that is organized and financed differently, but finance isn't first. But if we're thinking about health creation and human-centeredness, I think we make decisions in a different way. I think we create value around health that is fundamentally different than what we do now, which is we try to save money and create financial value on medical care and only medical costs. But if we were able to orient around what does it take to address known drivers of health, that seems so simple. Like I almost feel embarrassed to say that out loud at a cocktail party, because of course we would address known drivers of health. We're health professionals, right? But that's not actually how I believe the system is built. So I think the biggest opportunity to create value is around creating health and doing it in human-centered ways. Good question.
All right, next, we have a question from Susan Fisher-Owens.
Special populations whom you thought would be ideal to target for primary care. I'm wondering if you have modalities that you can share with us about how to identify these patients without labeling them.
So I think I missed the first part because they were a little late in getting you off mute, but I think you were asking about some of the special populations. How do you not? So I actually would say, again, come back to the relationship. I think clinicians know who they are. I remember Farzad Mostashari in the early days of Aledade, which is an ACO, trying to help people use their health IT systems to identify, different categories and populations of patients based on the data in their record. But what he did first was sat down with the lead clinician, the physician at the practice, and said, you tell me, make a list, tell me who's at risk in these categories. And she nailed like 97% of it without even using the electronic health record. When clinicians are in relationship with their patients, I think they know who needs to be supported and lifted into health creation. And of course, I'm a big fan of health data. Most of you know me know that. So use health data as a buttressing. But when we're in relationship, it removes our ability to be othering people, to label them and put them, objectify them in that way. When we're in relationship with them in a human connected way, we don't actually do that. That's my belief.
Susan, I saw your hand go back up. Did you have a follow-up question?
Yes, thank you. I was going to say, absolutely agree with you within the relationship, but it seemed as with looking at these target populations, there are some that we would want to get to come into primary care so we could establish that relationship. And how do we identify them before that relationship is already established?
Oh, thank you. Yep, absolutely. So I was trying to explain this idea of it's a flip of our current model, which I think it's hard to understand. But this idea that, so first of all, the burden shouldn't be on primary care to do everything, like recognize and get the patients into the office. If we imagine the system as patients experience it, which is not primary care, secondary care, and tertiary care, there's like just healthcare, right? And we understand all the places they seek care, then those the places where they do seek care can be the sentinel and can actually reinforce and refer and connect back to primary care as a central asset in the community. So I would say it's not. So when I look at, I use my boyfriend for a reason. That guy is so hard to get to want to be healthy. Like, he is your classic, totally unhealthy and just a pain in the butt patient, right? I love him, but oh my God. But people know in this community, as I said, the Minute Clinic, the pharmacist, there are lots of other indicators that actually he would benefit. He falls into that fourth category, or whatever. I'm just using him as a personal example. So the burden isn't only on primary care. The burden is on the community of healthcare providers writ large to connect the right humans back who would really benefit from the skill set and the relationship that primary care provides.
Hi, Bob and Linda. We have about 2 minutes left in this panel, and I've got 7 people queued up for questions. So should we just start with the first 1 or 2 and then unfortunately have to move on? Or should we see
and I would ask the folks folks who have questions they don't get to, let's save them for the end of the day or bring them up in the break.
And I'm going to, while you guys are asking, I'm just going to flip back and forth between 2 slides. So if you got some questions, reach out to me.
Great. And so for Shauna Hudson was next, and then Brenda was after that.
Hi, Christine. Thanks so much for a very provocative and interesting perspective. I wanted to ask you, because one of the things that we've been sort of thinking about and we'll be grappling with as a committee is really the definition of primary care. And from what I got from your talk was really sort of this oppositional perspective in terms of minute clinic versus sort of what we think of as traditional primary care, and what you talked about in terms of relationships. So part one of the question is really sort of, is my sort of interpretation of what you said, what you were meaning? And then secondly, sort of thinking about, as we retool this definition of primary care and sort of think about sort of embracing versus really sort of a specialization in terms of relationships, how do you see that sort of unfolding, and what would your perspective be in terms of voicing issues for patients?
Yeah, so I heard two questions. The second answer is, I don't know all the things. I think if I knew all the answers that, around how to make this work, like I would have been advocating for it for a longer time. What I do think is that the way we make decisions has to change. It has to become more driven and supported by bidirectional empathy, a deeper understanding of the human needs at play in the system that drive our actions. I think it has to be driven collectively by patients and clinicians. It can't just be the clinicians anymore. It has been that way for too long. It's why we are where we are. So I think if we make decisions differently, there is, a lot of evidence around sort of the emergence of group intelligence. And there's a new way of thinking when we get diverse perspectives into the room. And that, I think, is what we need. So if we can create those things, number one. Number two, I think we have to think about, how do we value and prioritize relationship in the system? How do we make it possible in the constraints of the system we have, or blowing those constraints wide open to change the economics of healthcare, to give us more time together, more ability to create connection, more training for you guys on how do you actually do that from your front lines to your front desk, relationship building, creation, bidirectional empathy, and human connection. If that begins to permeate, I think that's an excellent starting point. And I feel like I missed the first part of your question, but I'll email you.
Sounds good. Thanks.
And Christine, would you mind if folks who didn't get to ask their questions today were able to email them to you?
Yeah, absolutely. I flashed my email. It's on the last. It's on the last slide. You can tweet at me, whatever you want to do.
Thank you.
Yeah. Oh, policymakers, Ben, good question. So that's what I want to do next. I think that we can do a version of the third conversation that includes policymakers and what you're describing as the medical industrial complex. We have to engage our decision makers as humans. We just finished doing 10 interviews with health system leaders, and people don't engage them as human beings. We go in and we point fingers and we fight about it, and we're just been buried by an avalanche. And if our next move, I swear to God, is fighting about what rocks go where instead of linking arms and helping understand and rebuild together, I don't know what I'm going to do with myself. So I think there's a different way forward that comes from a different place. That's why the third conversation talks about reinventing first the patient-clinician relationship, but then healthcare from the inside out, which is inside of ourselves, but also from within the system based on, our collective human experiences and knowing what we need. So thank you guys so much for the opportunity to talk today. Thank you, Ben.
Christine, thank you so much.